Hi, I'm Dr. Brian Slomovitz. I'm a gynecologic oncologist at Miami Beach, Florida at Mount Sinai Medical Center. I'm also serving as the IGCS co-chair for the Uterine Cancer Awareness Month campaign. We know that uterine cancers are the most common cancers that we see in gynecology, particularly in North America, Europe, Australia. It's the only cancer with an increasing incidence and most concerning, an increasing mortality, with the number of deaths outnumbering those of even ovarian cancer in most of the populations we serve. It's really attributed to a lot of risk factors we're seeing, and we need to really do a better job in identifying these risk factors and helping to eliminate and decrease the burden of death due to this disease. Today we have a very important panel discussion that we're going to be discussing the treatment advances in endometrial cancer. We're going to explore key developments in minimally invasive surgery, in the medical management of this disease, and really in the supportive management, most importantly in the supportive management, and what we can do on a day-to-day basis for our patients in order to help make their lives better. Our goal today is to not only share cutting-edge research and innovations, but also to provide practical insights on how we can benefit your clinical practice. I'm really fortunate today to be joined by a distinguished panel. First on my left is Angelica Rodriguez, my co-chair of the IGCS Uterine Cancer Awareness Month campaign and a medical oncologist at the Federal University of Minas Gerais in Brazil. Angelica?
Hi everyone, it's a great honor to co-chair this campaign with Brian. Thank you for watching us.
Thank you for being here. Dr. Tom Herzog, a gynecologic oncologist at the University of Cincinnati Cancer Center, University of Cincinnati in the United States, and also the president of the GOG Foundation. Tom?
Well, thanks for having me. I appreciate being able to join to talk about this important subject.
Great. Thanks for being here, Tom. And finally, Courtney, a nurse practitioner from The Ohio State University, also here in the United States.
Thank you. I'm happy to be here today.
Great. Thanks for being here. So thank you for joining me, all of you, and participating in this panel discussion. Let's get started. The management of this disease of endometrial cancer is really multimodality, especially for starting off with the newly diagnosed patients. The first step really is the importance of surgery. Tom, why don't you start off with you? I know you're in the operating room a lot. Tell us about some of the newer techniques, the newer approaches you have to the surgical management of our patients with endometrial cancer.
Yeah, we've seen a tremendous evolution in the management of endometrial cancer through the surgical modality. If you think back, it was the early 90s, 1993, I think Joel Childers published the ability to start thinking about doing lymph nodes and a lot of the operation laparoscopically. So you think about it, it's 30-some years. It seems like a long time, but some of us can remember back when that was all being published and presented. But that was quite a radical transformation from the large incisions that we used prior, right? And so we moved to minimally invasive surgery, and there's really two elements of the surgery I think are important. One is what is the incision or the route of surgery, and the other one is really how do you manage the lymph nodes? And are lymph nodes important? And we've had that debate for many years. And so the evolution's been very interesting. We did, through the GOG, Joan Walker and colleagues did a study called LAP2 that it's complicated. I don't want to take up the time talking about how to interpret a non-inferiority trial and so forth, but a lot of people just interpreted it as it was at least as good, with much less in the way of morbidity than what we saw with open procedures, much less in the way of wound infections, DVTs, neurologic injuries, and so forth. So, and lymphedema. And so there was some thought that this was the best way to go. And to show you how things have changed, I think it was Andrea Mariani from the Mayo Clinic, they wrote up that they were doing minimally invasive surgery in 20% of their patients in 2008, not that long ago. Right. And now it's over 95% are done. And the conversion rate for LAP2, for over a BMI of 35, which is like a normal sized patient for us, right? And many in the US, unfortunately, was 65% conversion rate. Yep. And just think of how the skills have changed. So we've gone to laparoscopy, then a lot of that transition has been to robotics. Yep. And so the robot has really changed things tremendously. But then and that couples with the lymph nodes. So sentinel lymph node mapping became the standard or a standard of care Emma Rossi's FIRE study, I think, was one of the ones that really codified it in Lancet Oncology in 2019. And I think that really has made a big difference in where we are. And so we've continued to see the adoption of that. Most all our fellows are trained on robots now. In fact, a lot of them can't even do laparoscopy. But so everyone's pretty competent coming out doing robotics with minimally invasive surgery. What it has done, which is a tremendous thing, is it's changed our census.
Yep.
So we have almost no one in-house from surgery on weekends and so forth anymore, because for endometrial cancer, because it's all done where they can go home either the same day and certainly almost in all cases the next day.
Yep.
So it's been a tremendous win for the patients.
I think you brought up, it has been, as we know, and you brought up a couple of important points. And, Courtney, I just want to ask you about this. You're a nurse practitioner. You're really the face of a lot of our clinics. You're really, we can't do what we do as physicians without physician extenders. But you're seeing patients that have an incision, maybe from other type of diseases, and you're seeing these robotic hysterectomy patients that are coming in, and sometimes it's tough to figure out who the patient is and who the family member is. What are some of your take-home messages or the advantages you see in the minimally invasive approach for your patients?
Yeah, I've been able to kind of see this evolve, and it's really made a positive impact on our patients. The surgical outcomes, they're coming in, they look much better at their post-op visit, much less post-op complications like Dr. Herzog alluded to. A lot of our patients will say, I can't even tell I had surgery, within days after having their surgery. So I think that we've definitely seen a decrease in readmissions, complications, but also our patients are feeling much better, significantly faster, and decreasing the length of stay for their hospital stay also.
Yeah, it's amazing what we're seeing. Tom, back to you. This is a global organization. Sometimes the resources aren't the same. I think you highlighted, LAP 2 was not a robotic surgery. We've progressed into robots, but, explain a little bit, our colleagues globally, they're still doing minimal invasive surgery, laparoscopy.
That's okay.
Yeah.
Absolutely. We have to be cognizant of the resources that are available, but the LAP 2 still provides, and now there's tools that may or may not be available in a particular country where you can do the mapping through laparoscopy as well. You don't need to have a robot to do that, right. But some people don't have that availability, right. So that needs to be stressed. But I still think that you can get the benefit of, even if you do lymphadenectomy with that, those patients are still going home same day or the next day. Yeah,
particularly our obese patients, because we know obesity is a risk for this disease.
That's right.
Angelica, I know you're going to focus on the medical management, but touching on surgery, how much quicker can you treat your patients who had minimally invasive surgery? How sooner are they ready for treatments, as opposed to those big old incisions when we have to give them a month to heal?
So it's clear that we need to start treatment as soon as possible, especially for patients with more advanced disease. And now we have some revolution happening also in the adjuvant setting. So if the patient was submitted to minimally invasive surgery, we can immediately initiate 1 week, 2 weeks after the surgery. And if it's not minimally invasive, sometimes we need to wait some weeks for the patient to recover, and it may affect the clinical outcome.
I think great points, and patients want to get treated. I think our patients are going home now after minimally invasive surgery with Tylenol or ibuprofen, so it's really
ready to start systemic
they're
treatment.
Ready to start. Yeah. They're ready to go. They're mobilizing more quickly and things like that.
The return to work is the amazing thing too.
Yeah.
I mean, I have a lot of women that are back. If they're not doing heavy labor, they're back to work in a week, 10 days.
We often get phone calls and say, I feel so great, can I go back early?
It's really incredible. Okay, so we've done the surgery. Fortunately, in these patients, 2/3 of them I consider one and done. They have their surgery and they're treated. They recover, they go back to their productive, healthy lifestyles. But let's talk about the burden of the disease, the deaths due to this disease. These are the ones with advanced or recurrent cancer, and they need more systemic therapy. Okay, and the last couple of years, we've seen a complete turnaround, really a revolution of how we're treating these patients from the first line onward. Angelica, you're at the forefront of this. You're really helping us lead the efforts in the ongoing trials and our future trials. Can you spend a couple minutes and really run down some of the changes we've been seeing and the excitement you have about this?
Yes, it's amazing. We are witnessing a revolution in endometrial cancer treatment, not only in surgery, but also in systemic treatment. And this revolution started 10 years ago. It was started before, but 10 years ago, a decade ago, it was presented, the new classification, the TCGA classification. And according to this classification, it's possible to classify patients in a lower and higher risk and treat them accordingly. So currently, it's mandatory to see if the patient has a POE mutation, and if the patient is stage 1, 2, if this rare mutation, but which implies a very good prognosis, it's possible not to indicate adjuvant treatment in context that sometimes we would indicate chemotherapy or the combination of chemo and radiotherapy. So this is fantastic, and this population is almost free of risk of recurrence. And for those patients who need more treatment, there are very good advances as well. And 2 years ago in 2023, especially for patients with advanced metastatic disease, we had very important advances with the incorporation of immunotherapy combined to chemotherapy in first line. It improved not only progression-free survival, but overall survival, especially for patients who are mismatch repair deficient, but not only, also for patients who are proficient. We know that those patients who have this deficient, they are quite sensitive to immunotherapy. Patients who are proficient, they are not so sensitive to immunotherapy, and we are trying to build in on that. For example, trying to include PARP inhibitors, trying to identify those patients who are HER2+, and these biomarkers are going to lead what we need to do for each patient. So the first revolution was the introduction of immunotherapy combined to chemotherapy, the combination of immunotherapy and target drugs just like lenvatinib and immunotherapy. And now we see the ADCs coming and very good results with this agnostic indication for HER2 3+, 2+ patients, and now we are going to see so many results with ADCs, a new era in the treatment of endometrial cancer for sure.
Yeah, no, that was a great review. Thank you. And really talking about how the molecular classifications, starting in 2013, and then doing the PROMISE classifications, really highlighting which treatments should be used in our patients. Tom, I want to talk immunotherapy. Are you giving it to all of your patients? How much did the implementation of immunotherapy change your practice?
Yeah, that's a difficult question. Certainly in the DMMR, the mismatch repair deficient patients, I offer it to all of them. And I offer it to a large number of the MMRP, the patients that are MS stable. It's a little hard to know what to do. There's variances between the studies. If you look at, say, Ruby versus GY018, I mean, you have Pembro there, it has a ratio of 0.54. So there's benefit there. And even with dostarlimab and Ruby, you see a benefit. It's not quite as dramatic, but it's there. And the trial's different, so you can't go, it's not a direct comparison. But I think it's really interesting. When you look at it as a steward of healthcare resources, I sometimes debate how important it is to add to that patient that is mismatch repair proficient. Yep. But when the patient's sitting there in front of you and you want to do everything for them, it's sometimes, and they're otherwise healthy, and I do that. So if someone is very frail, that type of thing, I may be a little more reluctant to do it in someone that's MMRP. But MMRD, I'm going to try to do everything I can to put them on it. I mean, the hazard ratios, how much of a reduction that you see in the risk of progression or death, it's almost a 70% reduction. It's crazy.
Right. Yeah, I think that was a nice overview, and you also highlighted the difference in patients clinically. And Angelica, you talked the difference of patients from a molecular perspective. Yeah. So I think the more and more molecular testing we're doing, maybe it's not an immunotherapy in the first line, maybe it's a HER2 targeted agent or some other targeted therapy, which is interesting. You also, Angelica, highlighted lenvatinib pembrolizumab. So Tom, to your point, whether we use immunotherapy in the first line or not, we have something in the second line that's immunotherapy based, which is really, again, great for our patients. Courtney, related to this and we're going to dive a little bit deeper into supportive care, but particularly with immunotherapy agents in your clinic, how easy is it, or how difficult is it to really that it changed the standard of care for a lot of patients?
I think it was a gradual process. You know, when it first came out, it was very new to a lot of people. These are new side effects that we're not used to managing. But I think now we're very comfortable with it, and we've used a multidisciplinary approach with our pharmacists referring to pulmonology, things like that, to help us make sure we're managing these patients. But I think it was gradual, but I think now we've really evolved into it and we're using it a lot, and I think for the most part everyone's very comfortable with it.
Yeah, that's it's amazing. The more you use it, the more comfortable you are with it, and things like that.
And so now we're trying to figure out how to use it with combination therapies and deciphering, you know, overlapping
Which
side
drugs
effects
cause and which side effect,
Yeah, it's really, again, it's nice, and it's not as difficult as it was when we implemented it.
Right.
Angelica, you talked about antibody-drug conjugates. They're in practice now a little bit. In the U.S., we have a indication for trastuzumab deruxtecan. But let's focus a little bit of working with you. You're helping us to be a global co-lead in our research efforts. And a lot of times in the antibody-drug conjugates, you know, in doing what I do in the uterine cancer portfolio research, we have about 13 or 14 trials, either ongoing or planned, using ADCs in endometrial cancer. Talk to us a little bit about the importance of evaluating which is the best ADC, because right now we have no idea which one's really better than the others.
Yes, I think that we have a challenge here. We don't have so many biomarkers to guide it. I think that we need to identify better biomarkers for to go forward with ADCs, and also to try different payloads. We are focusing on sometimes changing the target, but we are using the same payloads, and they are quite similar. And I think that with this strategy, we're staying at the same. We're going to stay at the same place for a while if we don't identify different payloads. So I think that this is a new era, but I foresee some challenge at this moment identifying targets.
Great. Tom, more of a general question. You lead the GOG. Clearly, research is important. Can you, you know, we went from doing individual studies in individual countries, taking 10 years to get an answer. Just really sort of highlight the important work that you and your group's doing in order to get answers quicker on a global level with partners like Angelica.
Yeah, I mean, that's what makes it so great now, is we can answer questions at an accelerated rate, and we don't have to recapitulate the same trials. So for many decades, in the 80s, 90s, and early 2000s, if something was done in Europe, it had to be recapitulated in North America, and vice versa. And so our most valuable resource, our patients, were being wasted. And so now we can move on to adding another question in and keep the field moving forward.
Yep.
So it's been instrumental in transforming the standard of care at a more rapid rate, which is really important. So I think global interaction, and thank you for our partnership.
Thank you.
It has made such a big difference, and we can answer these questions so much better and more quickly with robust trials that give us definitive answers.
And Courtney, you're on the ground. You're treating patients. Some of them going on research, some of them are not. How just can you give a little example of what it's like, the daily close interaction you have with your patients? And you're at Ohio State. You guys are putting a lot of patients on trials.
Yeah. I think that it's a benefit to a lot of these patients. They're getting access to medications that they otherwise wouldn't have access to, and for the most part, it's a very positive experience for the patients. We go in, we talk to them about what the trial entails. Most of the time, they're very interested with very few reservations, but we make sure we talk about pros and cons of that. They meet with the research team, they go over the consent form, and then we just start the screening process. And so it's pretty seamless because we have a great research team at Ohio State. But I think it's definitely opened a lot of opportunities for patients that they otherwise wouldn't have had if we didn't have these clinical trials.
Yeah, that's great. And a lot of times people think, well, you can only get clinical trials at Brazil or in the United States. We're doing these trials globally. We're working with our colleagues in ENGOT. We're working with our colleagues throughout South America, throughout Asia, Australia. So it's really, Africa, it's really important to expand our research efforts, and really, that's how we're going to make a global difference. Last couple of minutes, I just want to focus on a topic that I'm very passionate about, is prevention. The best way to treat cancer is to prevent cancer. Courtney, what are the conversations? Patient comes in, obese patient treated with a grade 1 endometrial cancer. What are some of the other, in order to prevent other cancers or other health problems?
Yeah.
Just talk about, maybe even before they had endometrial cancer, what is our message as healthcare providers in order to help decrease the diseases?
Well, obesity is by far the biggest risk factor for endometrial cancer, so it's really important to emphasize the importance of lifestyle modifications with diet and physical activity and making sure they're aware of that, not only to reduce the risk of endometrial cancer, but other cancers and other comorbidities. It's also important to talk about other risk factors, signs and symptoms of endometrial cancer so that they can raise awareness for their other family members, friends. Another thing that we're going to talk about today is, I think, a barrier that endometrial cancer disproportionately impacts African American patients. So I think raising that awareness too, that's partly because of late stage diagnosis, barriers to healthcare. So I think as healthcare providers, finding out why do these patients have more healthcare barriers than other patients, and what can we do about it as healthcare providers to make sure everyone's having good access to healthcare.
Yeah, those are great points. We're almost finishing up here. June is Uterine Cancer Awareness Month. The color of Uterine Cancer Awareness Month, it's not a coincidence. Tom and I are both wearing peach ties. We have our peach ribbons on. We need to it's an awareness campaign so people know how to better prevent cancer, how to seek out the right surgeon to get the surgical management of the cancer, and what the best therapy, I should say chemotherapeutic agents, but systemic agents are, maybe going away from chemotherapy. Really an exciting time. Tom, start off. What is Uterine Cancer Awareness Month? What do we need to do? Just comment a little bit, just briefly, the importance of this.
I think the fact that we've seen what you said in the intro, Brian, is so important. We've seen an increase in the incidence of the disease. We've seen an increase in the mortality or the death rate from this disease. And importantly also, we didn't talk much about our underrepresented populations.
Yeah, of course.
But it's been a travesty what we've seen in African American, blacks in the United States and elsewhere,
yep,
where we see the mortality more than double in some of the stages and some of the molecular subtypes. So we need to understand this disease better. So we've learned so much on the molecular basis, but we are still redefining and learning more about how to use that information, and we'll have new information to adapt into individualizing care. But I think raising awareness of prevention, screening, postmenopausal bleeding, abnormal bleeding, all those things, because if you get to the physician earlier, we can help so much more. It's great if we can get these patients into the 2/3 or the third, you just don't have to worry about it all, right?
Yep.
And that's what we need to do. And that doesn't always happen even if it's early because of the more risky molecular subtypes. But if we can use this month as a platform to be able to communicate these 3 or 4 basic messages of prevention with diet and exercise and recognizing symptoms early,
I'd say a lot of our patients come in and they have no idea that postmenopausal bleeding is abnormal. They just thought they were spotting, and some of them have had it for months to even years. And I think also healthcare providers need to be aware, that's not normal. I've had patients say, I told my provider I was spotting, and not acting quick enough. So being aware of the high-risk patients, but also making sure you're screening all these patients that are at high risk.
Angelica, I'll give you a chance for a last comment.
It's not a U.S. problem, it's a global problem.
Yeah.
I would say that in low and middle income countries, patients misunderstand the concepts. They know about cervical cancer, but they don't know about uterine cancer. And so awareness about endometrial cancer is fundamental if we want to progress, to reduce incidence and mortality. It's increasing globally, not only in high-income countries.
Right. Globally, not just postmenopausal women, not just obesity. Tom, you highlighted, and it can't be highlighted enough, diverse populations. Mm-hmm. Black women twice as likely the risk of death due to disease in the United States than white women. These are all the problems, the issues we need to raise. The conversation doesn't end here, it really just starts here. Yeah. Yeah. We need to take home, the viewers out there, take this conversation, talk about it with your colleagues, your patients.
And I think you bring up a good point about the postmenopausal too, because we talk a lot about the patients who are high risk, but I've also had younger patients come in and they're having symptoms and their provider said, you're too young for endometrial cancer or you don't fit this criteria. always have differential diagnosis of endometrial cancer until proven otherwise if they're having like abnormal bleeding or other symptoms.
And what an opportunity to bring up too, because it could be a Lynch patient,
Yes.
right? Lynch syndrome, and it's the opportunity to save her other cancers, but also, you know, to do cascade
exactly.
testing and save family members' lives. So it's wonderful that we have this month to put a spotlight on all these issues for endometrial cancer.
Yeah, no, thank you for that. This has really been great. First of all, I want to thank the IGCS, obviously, for bringing us together, for leading the global efforts to help eradicate this disease. And it has to start with these type of conversations. I want to thank you all for your time. We're really excited about the month of June. Jump for June, jump for the cancer. Let's help get rid of this disease. And again, thank you for being here. We look forward to next year talking about the latest advances we have over the last 12 months.
Yes.
So thanks, everyone.
Thank you.